All right, moving forward, diabetic emergencies. Of course, the formatting of the SMO has changed. IM glucagon. As far as glucagon goes, we're used to giving it intranasally. Intranasal route is going to be taken away due to the fact that the concentration we had been using is not appropriate for intranasal administration. So it's going to go back to intramuscular. Also, with pediatric patients under 2 years old, the use of D10 is in there now, starting with the intermediate level, intermediate and paramedic. And you can use it on any patient that, for example, would have fragile veins, where you'd be a little bit more afraid of pushing that heavy concentration into them. Quite a few things here besides the formatting change. With our do not resuscitate pulsed, which is the practitioner's order for life-sustaining treatment. That form is in there at this point in advanced directives, but we've added more information to the SMO as far as information on living wills, power of attorney, and hospice. Living wills we cannot accept in EMS. So if you were presented with a living will, that would be call medical control, tell them what you've got, and have them guide you through the process on scene. Power of attorney for health care, and it needs to be for health care. If they're on scene and can show documentation that they are truly the power of attorney, they can make decisions concerning the medical treatment of the patient or refusal. When it comes to a DNR order, if the patient has signed the DNR order, the PULSE form, the power of attorney cannot rescind that. But if the power of attorney signed it or another surrogate, not the actual patient, they can make changes to that. They can rescind if they want to. Hospice, if you're presented with a hospice patient and they don't have a copy of a DNR there or can't find it, it is pretty much assumed that if you are a hospice patient, you do have a DNR. That's just part of how that's set up. The PULSE form has direction for a patient that's not in arrest. So if you haven't looked at the most current PULSed, there probably is some copies around here, but there is a copy of it in the SMO book itself that you can look at. And in the first section of it, the patient will determine if they want full treatment in the event of cardiac arrest, or if they wish to have a little bit more of a selective treatment. Then in the second box of that PULSed form, they will pick, identify which treatments they want in the end of life. Format changes for drowning, near drowning, and emergency incident rehab. That's pretty much it. For excited delirium and extremely agitated patients, all levels at this point will be using the albuterol if there's some signs of hyperkalemia with these patients. And that's albuterol only. You're not to use the duo-neb. For ILS agencies, no big changes. They're still going to have the option to use midazolam. When you move to the paramedic level, they can use the ketamine or midazolam. For the paramedic level only, with a patient in hyperkalemia, calcium gluconate has been added. And here's just an excerpt from the SMO about excited delirium, showing where the ketamine or midazolam would be used, who's going to use it. There it says in yellow, starting at the intermediate level, once patient's calm, get an IV and give them fluids. And if they're hyperkalemic, you also want to start with fluid boluses, try to dilute that out a little bit. Gynecological emergencies, hemorrhage, pretty much format changes. Hypertensive crisis, the addition of metoprolol is in there for paramedic level. Hyper and hypothermia pretty much stayed the same other than formatting. Inbound report and alert notification. This isn't really much new other than definitions have been added to what the reports actually mean. The heads up report, probably do that a lot right now, whether you knew the name of it or not, it's up there. But the initial report given early, given the hospital some advance notice, we got multiple patients or we've got, a serious trauma coming in, just a quick blurb to alert the hospital that they might need to pull together some teams to try to take care of the situation. The abbreviated radio report is pretty much the type of reports you do on a regular basis. It's just, quick, concise information to relate to the hospital so that they can kind of triage that patient and know what to do with them. If you need to get medical control involved, you're going to ask for orders. That would be a good spot to do a detailed radio report where they're getting all the information you've got so they can make an informed decision. Here we show the different alert notifications. Some of them you're already familiar with, like the STEMI alert, stroke alert, and trauma alerts. Probably have all done those at some point. Some of the other ones we are looking at that we do want you to call to the hospitals with advance notice. As soon as you can would be a burn alert, and it gives you criteria there what would be the ones you would want to call. Unstable pediatric patients, and then the sepsis alert, which is a new SMO that we have, and Richard will be talking about that one. As far as infield termination goes, if you got a patient that's obviously DOA when you get there, you do not have to start CPR, and medical control is not required to be there. So what would be some examples of something obvious? Rigor, injuries not able to sustain life, like decapitation, organs, all over the place. Gunshot wound through the head that goes clearly, entrance and exit, clearly through the midline. Injuries like that. It could be that you've been presented with a DNR, a valid DNR. So those would be issues that you can not start resuscitation, and you do not have to call medical control. If resuscitation has been started prior to your arrival, resuscitation needs to continue, and then you can contact medical control and ask for advice as to how you want to do that. When termination is approved, if it's approved, then you would be responsible for contacting the coroner or making those arrangements. For intermediates and paramedics, if they've been on a scene trying for resuscitation, if they've been there for 20 minutes or more and they have not got a return of spontaneous circulation and do not have a shockable rhythm, that would be cause to call medical control and see if they would advise termination of efforts. Also, if capnography remains below 10 throughout the resuscitation attempt. Special situations, if the patient is hypothermic, it's been submerged in cold water, if you've had transient return of spontaneous circulation throughout your attempt, or you continue to have a shockable rhythm, those would be reasons that you would continue your resuscitation effort. Inline nebulizer, pretty much just formatting changes. Same thing with intercept criteria. This is not all that new, but it doesn't address expanded scope and critical care transports. That has to be more of a system-specific SMO that would not be included in this SMO. Intranasal medications, so we've got an additional medication with fentanyl. Maybe it's not that new, but we have taken out Valium and glucagon. Glucagon I explained earlier. Valium just has a problem with absorption. But the medications you can use with the MAD device would be naloxone, midazolam, fentanyl, and morphine. And when you're using an analgesic, fentanyl is the preferred for that. As far as intraosseous goes, it's just more of a generic, taking out the manufacturer's names and not really us giving guidelines as to how the insertions should be, but use whatever device you're using, follow manufacturer recommendations for its insertion. Intubation, emphasis on pre-oxygenation, so high flow oxygen with the bag valve mask, and in a patient with no contraindications, considering CPAP before intubation. Tony had mentioned earlier the 3 methods of confirmation minimum, getting confirmation that the tube is in the trachea. And those, a list there of the confirmation would be end-tidal CO2 if you've got it, colorimetric device, visualization, direct visualization, auscultation, listening for gastric sounds, absence of gastric sounds, misting, bougie confirmation, an esophageal detector device, and bilateral chest rise. You want at least 3 of those documented. Narrow complex regular tachycardia. Aside from the format change, you've got regular added there. It was just narrow complex tachycardia. Put regular as far as rate goes, because when you have the irregular rates, adenosine tends to not work and really isn't recommended for AFib and aflutter. Needle crikes, just format change, nothing big in there. Needle decompression, talking about the IV needles that we have always used, you know, the 14 gauge 2-inch. It's now recommended that it should be a 14 gauge, but the longer catheters, so 3 1/4 inch is what's needed for adults. Quincy, notification of coroner. I guess that picture has something to do with the age of who put these together. The group.
Yes, the group.
Pain assessment and management, formatting, but the consideration of using ondansetron before you give narcotics, just to help with that nausea and vomiting. Ketorolac, fentanyl, and morphine are options for the intermediates, and the addition of ketamine for extreme pain for use with paramedics. If you've got a patient with extreme pain and the narcotics just aren't cutting it for them, you've got that as an option. Also, paramedics can consider the use of diazepam or midazolam for musculoskeletal type pains. And there we just go through that SMO showing the consideration of the ondansetron prior to narcotic administration, and the different uses for the ketorolac, which I'm sure Kirk will hit on those. Ketamine, again, if the narcotics are not cutting it, not relieving the pain for that patient. You've got the use of ketamine that is intramuscular injection. Be aware when you're using the narcotics, especially if you're doing repeat doses, of the possibility of a narcotic overdose. So, make sure you've got your Narcan available to you, ready to go. If you use narcotics, if you use naloxone, that patient needs to be transported to the hospital. Morphine and fentanyl and ketamine do have the potential for abuse and addiction. So when you have them as an agency, and this I guess will be determined per system as to the requirements for storage and accounting for those type of medications. So you'll have to get that information from your system, but there will definitely be, paperwork involved in it and lock boxes and all that for any type of storage of those 3 types of medications. Pediatric airway, Tony had talked a little bit about that, but what's new about it, and it's big, is taking the ability of intubation out of the SMO for patients 30 kilos or less. So that puts you at about age 8 for your patient age, and replacing those with the supraglottic airway, which is, in our case, the King airway. And we have sizes 0, 1, 2, and 2.5. And of course, the adult sizes will remain with us as well. But that's just, again, the studies, the data just shows that this is probably the best route to go. Some of the pediatric SMOs that only had the formatting changes, or they're alluded to in the adult SMOs, allergic reaction, anaphylaxis, altered mental status, cardiac arrest, asystole, PEA, burns, drowning, near drowning, dysrhythmias, tachycardia, head trauma, neonatal resuscitation, seizures, shock, toxic exposure, VFib, pulse, VTAC. Just pretty much formatting. Pediatric respiratory distress or arrest. Contact medical control for persistent bronchospasm. And if you can't break it with, your usual means like albuterol, you may be able to move on with medical control advice to magnesium sulfate, or the methylprednisolone would help with the reducing the inflammation.
My favorite picture.
That's not mine, right?
No. All right, we'll just
It's Dr. Conrad on scene.